Thank you, everybody, for coming to the Bellfire 16, meaning for our 16th anniversary. We start off this live event with some education. We're going to change up the order. We're going to start with our panel of experts. My name is Barbara Strain. I'm the chairman of the Bellwether League Foundation this year, and it's really a pleasure to have you all here today and to participate in all of the festivities that we have going on. So without further ado, I'm going to introduce Carl Meyer, our class of 2019, who's going to moderate and introduce the panelists. Thank you, Carl.
Good afternoon, everybody. Hopefully the next 45 minutes to an hour will be educational and entertaining. We've got 4 great panelists today, and I think that the rest of the day following this evening, getting to hear from our guests will be exceptional as well. To start with, we got Tom Lubotsky on the far side, head of supply chain at Allina, a native son of Milwaukee, so he feels right at home here. Ed Hiscock from supply chain at Trinity. Did you drive or fly today? I'm guessing you drove. So he's a man behind the wheel. We're blessed to have Susan Chakowski with us from Owens & Minor and Kyle McMullen from Medline. So welcome our panelists, please. Over the last 10 years, we've seen the roles and responsibilities of supply chain leaders expand, creating new and exciting interactions that go beyond traditional duties. One of our guests will be inaugurated later today. 2 years ago, coined the phrase that the urgency is taking precedent over the important, and I think our industry is really dealing with that even to this day. So we'll talk about that as part of this. They include business consulting, landscaping, project management, real estate, and even revenue-generating products and service incubators. So what I'd like to do is start with you, Tom, and talk about some of the things that are impacting Allina and some of the ways that you're seeing supply chain change as we move forward.
Yeah, so the one area that just jumped out on me was we've been all working on it. I think the impact is getting more pronounced each year, and it's the whole area around diversity and inclusion. So supply chain has a clear role in terms of the supplier diversity efforts and expanding its community reach in terms of local suppliers, small business or suppliers. But I think when you start looking at health equity, it becomes a little bit more different in the sense of which communities need more assistance with health. And is there an opportunity for supply chain through others to begin to make advancements in building out those communities and enriching them with the ability to have more of a business associated in those communities to grow them and so forth. And then the other part is around looking at the disparities around healthcare is provided. And this provides really good opportunity for our suppliers to work with us because they're also examining kind of the disparity of their products and devices and so forth, and begin to really examine how do they get used in the sense of providing what they had always wanted was the equitable way in which it should be used in advanced care. But there are indeed disparities around all of that as well. So that was the one area that we are beginning to address more in a more pronounced way. I mean, I will tout a clear example. It's not Allina, but in Chicago with Rush and the work that they've done on the west side of Chicago with linen and laundry and putting a business in there. And I know that they have been very, very active in building out with the sensitivity around the income levels in those communities and what can they bring together. So those are some really sound collaborative effort that I know that sets a good example. So our reach beyond just the conventional way of thinking, the whole area of diversity and sustainability and building out communities and equitable amount of care is, I think, an extension from.
Ed, do you want to comment?
Sure. Yeah. think that's perfect. Can you guys hear me all right? Everybody was the guy in the front row. It's loud. It is real loud. Very loud. So, Tom, building off of your comments about kind of grounding in the communities that we serve, because we have an impact then, I think to your point, of impacting the health of those communities, right? You know, when a sizable organization can move its business into a local community, add a shift, right, at a place where people raises the socioeconomic status of that community, which is just one of those social determinants of care, right? So I think that there's certainly a role that we can play there. The question was more broad, right? Just kind of overall. My answer to that lately has been, we're going to get more supply chain. And that's not a term. I'm also learning new supply chain terms. Clumpiness. You guys know what clumpiness is? David and Richie were telling me the other day how clumpy I am. And it's a supply chain term. It has to do with variability in your demand signal. So when I talk about getting supply chain, we're going to get much more into the technical aspects of the profession of supply chain, in my opinion. We flat out have to. I'm driving clinicians nuts in my organization talking about a patient bill of materials. And of course, I'm in southeastern Michigan, where we stamp all cars, and their first reaction is, we're not building cars. No. What we need is to be able to express our demand like the autos do to their suppliers upstream, so that together we can be more efficient. So I'm using those terms on purpose to try and drive people to open that textbook. If they ever went to a supply chain school or going by, open the textbook, look at demand forecasting, demand planning, kind of get into some of those supply chain terms. And I was complaining in the lobby to somebody earlier about, I overdid it this week, and I'm on 3 different panels. But the last one, I'm going to an event called Logi Pharma. And it's where our pharmacy suppliers, supply chain professionals go to convince about what's going on in their world. So, and there's another one called Logi Med, same thing. The suppliers, supply chain professionals from our med device suppliers go to that event. And it's interesting to talk supply chain to supply chain. And I think in there is an ability for us to kind of raise all ships and drive a lot of the waste that we have in our industry out in the trade relationships today.
Thank you so much. So just a week and a half ago, they had the HIDA meeting down in Chicago, and there were some similar conversations, but I'd love to hear first, Susan, from you, and then from Kyle, your thoughts and how your organizations are looking at the things that the providers just spoke about.
So I think if I look at it from the distributor's point of view, one of the things that we are challenged with is we know that supply chain leaders are stretched so thin. And while we all want to be that strategic partner and really roll up our sleeves and get into it and want to do things differently, I think we're all challenged in time. And that's been a big struggle for us as a distributor, because we all divert back to this very transactional relationship. It goes back to all of this, just the simple minutia of transactions. And we've got to get back to staying focused. I think, right, Tom, we're doing some work with you and with your team as well, but looking at things differently and staying the course of being strategic. One of the things that we're continuing to invest in, we have a ton of data. And we share our data, but how do we make it actionable data? And so investing in more data scientists so that we can truly provide actionable data. We talk about being transparent and giving people the information, but for us, it's creating proactive, and I would say utilizing AI to create more predictive demand signals for us, partnering, but how do we then get that information, the three-legged stool between us, the suppliers, as well as the providers. And so that's what we're really focused on, but it is a challenge. And I think we all tend to get very distracted. And so staying the course, being focused, it takes time and effort. And I think the one thing that we're really focused on immediately is shifting the work that can be done to be automated so that we can plan and have a strategic course.
I want to go, there's two things I wanted to cover on. The first one was the diversity, equity, inclusion, and I'm glad to hear you say that on the provider side, because on the distributor side of Medline, it's almost become like a success pillar for us too. But it's not just in our hiring practices, it's do we have the right type of diversity suppliers out there? Are we looking at minority and women-owned suppliers out there to make sure that we bring them into the fold and make sure that we've got the right products? It's also on the product side, do we make sure that we have, there's some products that are unique or specific to certain ethnicities out there. So do we have that right product mix? So when you're looking to buy products for your patient population, do we have the right products that you need to fit all of your patient population, not just the majority of it? We want to serve everyone that you serve. As far as partnering with, you mentioned being a strategic partner, and we agree with that. A big challenge obviously is the cost pressures that you're under and driving across as much cost out of your supply chain as you can. And we look at that. The other thing we look at too is what are the ways that we can drive cost out of the supply chain? And it may not be the price of the pump. We look at that, but there are other ways too. So we've got a lot of clinical programs which help drive down, can we lower readmission rates? Can we have programs that can help you do that? We have programs that can help you reduce HAIs, which are a big concern, right? Anything that's gonna cost you money outside of the supply chain, as a distributor, we don't wanna just move boxes for you. We also want to really assess your business and partner with our providers to make sure that we can find other ways that costs are kind of leaking out the back door, if you want to use that term, and how can we help you shut those down so you recoup as much of your revenue as possible. That's just a couple of different ways that we think about that question.
So Ed, I know that you're one that always likes to sit down and meet with suppliers and talk about ways to understand what you're doing differently that may be costing them money or not as efficient as you could be. Do you guys have teams on the distributor side that are willing to go and sit down with the providers? Because I know that some providers want to be transactional. Mm-hmm. They don't have the time right now, and many, I think, want to be strategic and have those conversations and understand where the negative cost drivers are. So you guys have teams on that. To you two guys, I'll let you take them in any order you want. As the patient is shifting to lower cost sites of care, and we're seeing more and more of this coming out of COVID, what are you changing in your approach to providing product where it's needed as it goes from the hospital to a surgery center to a doctor's office to a patient's house? I'd be curious as to what you're doing today and where you're seeing it going in the future.
So not enough, honestly, in my opinion, because COVID did speed it up, right? It's moving faster than we anticipated, and that's some of the revenue issues we're suffering, is all those alternate sites of care that patients are seeking out, as well as their hesitance to still come to that scary, great big acute care hospital, right? So, but what we've done specifically at Trinity is in our warehouse, we have co-located our specialty pharma there, which is small parcel to the home, so that we're kind of getting some of the tooling within that facility to enable us, should we start shipping in larger scale to patients' homes, to give us that capability. And it's interesting, you know, when you get into the particulars of it, there's a lot of things that you wouldn't normally have in a warehouse that you'll need in terms of tooling to be able to pick, pack, and ship small parcel, right? You need UPS World Ship or something like that to get the addresses right. And there's a lot of particulars you got to pay pretty close attention to. So we're trying to get ourselves in a more educated position for that future. And it's interesting, just some of the behind the scenes technology that we're also looking at, because it's not just getting product to where the patient is, it's also getting the technology to the patient so that they can communicate with their doctor from their home. So we have Trinity Health at Home, and we're looking at, should we own the full logistics, kind of outbound logistics for that product going to the patient's home. That includes an iPad, includes some product, all the Bluetooth wired devices, the scale, the blood pressure cuff, things like that. And then the reverse logistics when that patient comes off our service and we bring that back and have to decontam, test everything. So we're looking at the potential of having to do that and hubbing that through our warehouse right now. Right now we have a third party doing that. They do okay. But anytime those things are outside of your control, you have some leakage potential. So that's just a couple of things that we're doing in the moment.
Tom, how about Adelina?
Yeah, so this is probably more complex than our inpatient, business, because there's so many different channels that have to be met. So most recently in the last year or so, we reestablished and looking at our hubs where our nurses actually pick up their supplies to bring to the home. And I thought, well, why don't I make sure they're at the home? And they said, no, because sometimes we're not really sure what we really need. And so we just need it to be more convenient. So we actually expanded some of the hubs, made them more close to the clinicians, and that seemed to be working quite well. But as I look at this area, it's just such a web of different players and different services that are needed. And so trying to standardize who are the partners that I need to rely on that can, help me continue to produce a more efficient and responsive outpatient home supply chain is really the path that we're trying to just understand. What do we have today? And what does that look like going forward in the future? Clearly, we've got a group that, and we've done some outsourcing approaches here. So we used to have our own DME. We now outsource that to a third party. We used to do certain things that were insourced that are now outsourced. So these myriad of different partners is, in a sense, complicating what do I have and what's the most efficient path that we need to pursue. We have an IT team that's really clearly working on the remote environment and what does that look like for the future. And recently we partnered with a national company called Inbound Health for having them expand our market around the way in which we provide hospital at home. And so they're kind of grabbed onto our algorithm around how we do it and expanding that nationwide. So some joint venture opportunities in there have also been interesting, and it just brings a new partner in with new capabilities that we need to examine. So at the end of the day, there's a lot of work in this space, but it's kind of figuring out, well, where do you want to touch first and begin to figure out how to architect it is really the challenge.
Thank you, Tom. 3 years ago, my mother-in-law was in the end-of-life care, and one day all of a sudden I hear a doorbell ring and the FedEx truck or UPS is driving out of the driveway, and I go and here's a box of supplies from Medline that I didn't even know had been ordered. And I remember texting Billy or emailing her and saying, hey, I'm thrilled some of your supplies are being used. Unfortunately, the situation isn't that good. But I'm curious as to, if I traditionally would think of Medline, it was acute care, extended care. Now you're moving into the physician clinic space, you're moving into care at home. Can you elaborate for us, Kyle, on some of the things that you're doing to address those ever-changing markets?
Sure. One of the driving strategies for Medline for the last several decades has really been to follow the patient, follow the customer. So yes, we did traditionally, we were in the hospital space, long-term care space. We've broadened that to make sure we're following the patient everywhere. Part of that strategy is to make sure that you mentioned standardization. The goal is to standardize the process, standardize the product mix, to make sure that from the hospital to the long-term care facility, whether they're in a surgery center or a physician office, even home health care and hospice, there's a certain standardization across all of that as much as we can affect that. So we have dedicated sales reps in every space, dedicated service in every space to make sure that we're doing that. The challenge we've seen lately, and we've kind of reading what the market's doing, is and we talked about this at Heidi, you mentioned a minute ago, the census in the long-term care facility-based care is not returning to pre-pandemic levels. But that population's still retiring at the same clip. They're still needing care at the same amount. But where are they going? Well, if they're not going to facility-based care, they're going to home-based care. So they're going to home-based care. The challenge that we have is how do we still support our facility-based care, long-term care customers that have declining census? It's more challenging to get providers, and we've got empty beds. How do we fill that? Our costs are challenging because things are changing. At the same time, we've got an increase in our home health care, which also increases need for DME and supplies delivered to the home. How can we help support that? So we've ramped up our service in that level when it comes to, like you said, you got a box shipped from Medline. So we support a lot of DMEs that do that directly, but we also do it ourselves as well. So you could get a product from Medline. Sometimes we're the fulfillment house. Sometimes it is directly from us. But there's a lot of different ways that we help support that market, and it can be directly from us. It can be through our DME customers, but we're starting to really ramp up that space with home health and DME because we're seeing a shift in the overall long-term care market more to home-based care versus facility-based care. Just a few examples there.
So Susan, Owens has historically been an acute care house, but now you've got Apria and other at-home sites. Could you elaborate on how you're kind of taking two different paths to follow the vision?
So similar, right, to Medline, we run our businesses, our traditional med-surg acute care distribution. We also have a separate business that is our patient direct business, which is our home health business. And now we're in the process of how do you marry those together? I think the biggest challenge, as we do see the patients migrating from the acute care outside and into the home, there's a whole new challenge for many of us with hospital at home. I think it's incredible to see the numbers that they're projecting. I think the latest number I saw was a $300 billion market heading into 27, 28. That's an incredible, right, book of business that is a trend, and we all have to find a way to be there to help serve and carry that product through, whether it is from the acute care all the way into the home. The one challenge that we've had is how do you marry some of those systems? And so for us, it's developing and creating, I would say, a new product portfolio that extends both to our med-surg product line as well as our home health line, and marrying all of that together so it's a seamless transition, whether that patient is living with or is within the acute care setting or outside of acute care. It is a challenge, I think, for many of us because there's still disparate systems. The IT piece of it, I think, right, when you said about having an iPad, you know, we're doing exploration into where do you go? What is the bridge between your med-surg or home health distribution and telehealth? How do you marry that together? And so that's a whole other direction. And so right now we have all of these different projects that we're leading. And the real key is going to be how do we then bring it together so we bridge the gap. But it's working in partnership with our customers, hearing the needs. I think the one thing that's unique for us is being able to leverage two completely different distribution networks. Our traditional med-surg distribution is 45 distribution centers across the United States. We have hundreds when you start including our Apria and our Byram facilities. But the key there is, right, how do we then have our systems talk to each other? How do we service that patient seamlessly? I think that challenges with hospital at home, there's time constraints. It'll be, I think we've got to figure out logistical ways to serve that customer in a very timely manner. So more to come on that, but that's a big challenge, I think, on both sides of the house. And it's something that we've got to tackle quickly because it's happening at a much faster rate than we ever anticipated.
Thank you. This is for the providers. A number of years ago, Amazon was going to take over everything. And for a whole variety of reasons, that hasn't happened. But there is certainly, I think, what Amazon has demonstrated is that there is lots of spending that happens in provider systems. It's either rogue spending or not contracted spending. I'm curious as to what you guys are trying to do to get your arms around that. I know some systems have partnered with Amazon to get reports on what is being bought on credit cards and go back to you, but I'd be curious as to the two-year approach as to rogue spending and non-contracted spending and trying to grapple with that issue.
So this is pretty recent on our part. We've really begun to focus a lot on this discretionary spend, as you call it. So just even restricting the appropriateness and use of P cards and making sure it's getting into the right hands and people know what they ought to be buying and using it for. So the whole procurement policy has been redone in that regard. But even as you bring that into play, what you learn is that, well, I don't have everything on contract. And so you're going to have to use that card. But now that I know what that spend looks like, because with P cards, you don't have that level of spend detail as you do with something that's on a purchase order. So getting that detail is very hard and even more difficult to manage and review. So we're examining what those categories are. We do have our front-end platform that we use for ordering that is linked to Amazon and linked to other punch-outs so that people can appropriately order from the formulary versus just doing it on their own and purchasing through the P card and using it to pay and so forth. And then the non-PO invoicing, those are items as well that we're examining and trying to, bring all this into better control. So we actually have set targets with our sites of our hospitals and major functions and service lines around this discretionary spend, and we're tracking and trending it and just beginning to do that, and just begin to try to educate them more and expose them in a transparent way around what are all your teams spending that money on, and where's the most appropriate way, and hopefully get better at then evolving the contracts that we don't have so that they're obviously buying more efficiently.
Yeah, and it sounds very similar. We have an Amazon business account, and we rostered all of our facilities. So we see what's going through that Amazon account. The first couple of reports, like, why are they buying movies? Who's buying movies? You're thinking somebody at 2 East is, watching something on Prime, but no, it was for the long-term care facilities for our residents, right? So it was appropriate spend, actually. So not everything that appears discretionary is indeed discretionary. Well, it's all discretionary. Some's appropriate discretionary.
But I had the same discovery around movies.
Yeah.
And it was actually for mental health.
Yeah.
And there's some legitimate purposes. But you want to get the hands of the P card into the right people that are buying it for the right purpose.
Yeah. And I think the Hawthorne effect has probably been the best motivator for us. When you're in a time of financial crisis, everybody's watching, and the fear of a reduction in force just hangs there. And if you can show some discretionary, okay, I can tolerate the blue pen from Staples instead of going off and getting this other fancy one that I get from somewhere else, right? So I think just casting a light on it, measuring, monitoring, exposing people to what that spend looks like. And then when you're in a large system, there's a competitive edge there too. They start with, wait a minute, why am I the highest in discretionary spend in my ministry, right? So you got some of that in play. So Hawthorne effect is my friend.
Excellent.
Discretionary.
So pivoting back to the distributors, and Susan, I'll start with you. As the IDNs are expanding, emerging, and moving into these different markets, how is Owens & Minor restructuring their selling organizations and servicing organizations to meet this changing demand? And then Kyle, you can follow.
So the most recent, I would say, we've done a overhaul, I would say, of our commercial team to really support the IDN expansions. We also are trying to give one point of contact. We find that there's, and I know we all talk about that, right? We say we want to have one person calling on the health system. Well, that's impossible when you're calling on a health system that may have 10, 20, 30, 90 facilities. And so it's really creating, I would say, a subgroup that is handling and focusing on the IDN. The one thing that we've done most recently is really overhauled our customer service team to ensure that our customer service team has more latitude to make decisions and to be able to, I would say, appropriately move inventory around the system, being able to give, I would say, visibility where visibility is due. We have found that we handcuff ourselves sometimes because we have limitations on our systems. And so that's been the one thing that we've done is, I would say, reshift our focus from the commercial team. The other thing that we're doing is really, I would say, having more collaboration across our house for our patient direct. We know that we have to solve for some of this as we go into hospital at home, as we look at home health and bridging those two businesses for us. And so it's really creating cohesive teams across our entire business. And I don't know if you guys are doing the same, how you're structured, but that's one of the things that we find is we've got to work with our systems and almost in some cases create custom organizations to call on our customers. So there's not a one size fits all. If you're calling on a group and you're having a customer that you're dealing with 90 some places across the United States, I've got to deal with that differently than how I deal with someone who has a single location or 5. And so it's I think being flexible to accommodate that, but we've also got to be aware and take the cues back from our customers. So it's not a one size fits all. I don't think it ever can be, and I think we all have to be a little more flexible in truly being a partner and allowing us to serve our customers.
At Medline, we've called on the IDN at that level for a while, but in recent history, we've significantly increased the volume of folks on that team. It's not just an effort to sell to the IDN. It's really, and we use partnership a lot. We throw that word around a lot. But if you boil that down to what it really means finding out what the IDN's goals are. What do they want to do? Yes, we know they want to save money. Yes, we know they want to drive costs out of the system. But what are their goals as an organization? So we really get in and we want to assess their business, their overall business. And what we're finding, and this is not news to anyone, but it's no longer servicing a hospital only, and then we've got another group of people that serve a nursing home and another group of people that serve a physician office. Those are all vertically integrated now. So how do we as a company make sure that the product mix we have at the hospital is standardized across all of their facilities where it makes sense, and where it doesn't make sense, and they, like you mentioned custom a minute ago, can we customize a certain product mix at a physician office that may not be appropriate in a hospital? Every system's different. Some of them want standardized across the board because it saves them cost to administer the price of the pump. Others want to be able to customize that, and that's something that we've gotten good at Medline to make sure that we can do that. The other piece of it too, in terms of supply chain, is do we have the right unit of measure going to the right place? So hospitals may need cases. Sometimes they do want lung. Sometimes they want us to deliver to the nursing floor. Sometimes they don't. But if we're also supplying their physician office, they don't need cases of product to show up. They need it in a lower unit of measure, right? So it just depends on the facility. And there's a lot of points in between there depending on what the IDN owns. So for us, it's been a lot about adjusting to how do we serve not just the hospital, but how do we have our entire teams, you mentioned communication, across that. We were very siloed in, I'm a physician office rep and that's what I do and I only care about doctor's offices, but you really can't think that way anymore. They have to think about the entire system. They have to work with their IDN director that works with the C-suite, and they have to work with a surgery center rep who calls the surgery centers owned by a particular health system. So we've had to kind of break down what you're talking about. We've had to break down those barriers between our different sales organizations, and it's from the top down. So from the leadership ranks, they talk about this on a regular basis. Our product divisions have to be aware of the changing landscape, and then on our sales organizations, even in the field, they meet on a regular basis and they have initiatives where they work together as a team to support a large IDN. But it goes down to that. It's communicating across the board from a sales standpoint, and it's working with the IDN as a whole, not just as parts of the whole.
Sure.
You brought up, when we talk about products, I think we have to somehow break down the barriers of what we traditionally have done as a med-surg distributor. And sometimes that's doing creative things, right? Carrying products that we maybe wouldn't have carried before, so that we can simplify or get that product from point A to point B. And in some cases, it's going outside and creating new products and portfolios that we would carry, custom ways to do that, so that we can truly be one for all. And I think it is a challenge because you've got some uniqueness. I think there's a lot of products that we all know that have traditionally been bought direct. And so how do we take some of those products that traditionally haven't flown through med-surg distribution, and how do we create one view, right, complete visibility from the end-to-end supply chain? And so those are some of the things that we're trying to do differently and customize so that we can serve across the board.
Great. So we're roughly 2/3 of the way through the panel, and we've got a lot of smart, bright people out here. I'm curious if anyone has a question. I've got a couple more here, but if anyone's got a question, Fred, go ahead.
You know, I just happened to be writing an article last week about moving care to the home. And I live in Cleveland, and Cleveland's got 3 basic systems. They got the Cleveland Clinic Foundation, you have the University Hospitals, and the mental health, they're the three big ones. And like you say, everything used to be easy when it was vertical, when healthcare was vertical. We had, it was focused in the hospital. Cleveland Clinic has over 100 locations in Ohio alone. So these guys over here that are working that supply chain have to come up with strategies to successfully service those 100 people. The thing that I found out in doing my research from the 2020 census, there are 170,542 households in Cleveland. So when you start to deliver care to the ultimate point of use, there's got to be a lot of coordination. How do you guys decide what you want to do? How do you work with folks to come up with a strategy? It doesn't sound like it's that tough until you start putting the numbers in here. And when the numbers get in here, it's not almost to get you away from doing it, but you have to do it. So anyone else?
Yeah, I'm going to retire. So, I think, and we're not there. We haven't solved for that. We know it's coming. We know it's something, and like I mentioned earlier, it is daunting. You're right, Brett. And I think that we're trying to prepare, and I'm going to get a little supply chainy because, and I got a question for you guys for that.
Absolutely.
But it's about the cost to serve. What is the best, lowest cost to serve? I was in front of a group of suppliers the other day, and I asked, do you know how much it costs to sell to me, Trinity? Nobody wanted to raise their hand and say no, but everybody was a no when they found out it was comfortable that nobody had a yes in the room, right? So none of the suppliers selling to me could differentiate between what it costs to sell to Tom and what it costs to sell to Trinity and what it costs to sell to the clinic, right? That's just not a thing in our industry. Outside of our industry, it's not only a thing, but it drives how much you pay for that product or service. The cost to serve you. So we, a long way to get back to your question, Fred, but it really is about just preparing for a future state and then being able to know that, all right, here's the capabilities I can deploy, and that gives me a cost to serve of X. And if I hire this third party, it's a cost to serve to Y. Or if I get 15 other third parties and do a piece of it myself, that's another cost to serve equation, right? So it really comes down to getting more sophisticated around what is our cost to serve that 100 and however many millions of locations you just talked about in Cleveland alone. But so that's another articulation of kind of where my head goes when I talk about us needing to get more supply chainy, figuring some of those things out, understanding our capabilities, our partners' capabilities. And is it a thing for you guys? Do you have your customers segmented by cost to serve?
Not that I'm aware. I mean, it's not a number that I'm aware of. We track, not on my end. We might do that on the sales side, but not on the distribution side.
We're starting to do it, and it's complicated.
Yep.
It is not easy, and it's not just a pick, pack, and ship model to service 170,000 households. It's a combination of that, and I think it's getting down to the true cost to serve. Just when you think you know, right? Something else comes up in the back, and so that's something that not only are we trying to figure it out, but I think it's constantly changing, and it is a moving target for us. But I think I go back to, right, how do you serve 170,000, right, with the same formulary, with a pick, pack, and ship model? I don't think any of us, right, that's a challenge. We do that today on our patient direct side and our home health side, but they're segmented into, like, different chronic illnesses and different disease states, and so you've got different formularies. But now take that and transport that and create a mirrored formulary that comes out of the acute care. It's a lot of moving pieces. That it's a puzzle that I feel like we get about 20 pieces of a 2,000 piece puzzle put together, and then right, you lose a piece. And so we're constantly, I think, chasing that right now and trying to figure that out. I think the one thing that's helping us is leveraging AI to try to figure out some of this and to figure out the true cost to serve. But I don't know if we'll ever do it yet.
I think just to touch on what you were saying really quick, what's made Medline successful in that place is scale. Like I mentioned a minute ago, we serve the entire continuum. So patient home direct is not new for us. Long-term care is not new for us. Hospital is not new. And I think the fact that we have the scale that we have, we've got the supply chain, we have 95+% of our customers are within a 1-day shipping point. That's not hospitals, that's customers, all of them. So we get, and that's on our trucks. So the fact that we own the warehouses, we own the trucks, we own the fleet, and that's everything from full-on 18-wheelers all the way down to our trucks, our small trucks that deliver to things like Amazon trucks, deliver to our physician office customers. Because we have the scale and because we own the supply chain, every bit of it, we're able to partner with folks who need to get to the 175,000 households there. Now, sometimes it goes on a FedEx, like you mentioned. We put on a FedEx, we deliver to the home. But we can deliver to a wide range of customer types. Because of the scale, we've got the agility to do that and to adapt to the market quickly. Are there gaps? Certainly. Is it easy? It's incredibly complex, right? When you get a product that ends up at your home for patient home direct, a lot of times you don't realize how many different companies and hands it has gone through to get from the manufacturer to your house. You think, well, 3M made it, or I'm picking a random brand, right? Medline made it, Owens made it. You might think it went straight to your house. It probably did. It probably went through 3 or 4 different companies. It's incredibly complicated how that happens. So what we want to do is try to streamline as much of that as possible. It drives cost out of the system. You probably want to streamline that on the provider side as much as possible. I know we do on our side, but it's a complicated business, and you're right. So I think as much as we can use our expertise, our supply chain to help your business, that's where we start to see things improve. So that answers your question, hopefully.
Tom, anything to add to Fred's question?
No, let's move on.
Hi, Greg.
So we gotta be careful with the words that we use and the service to what's going with the patient that we're trying to take care of. So the calculus, Fred, for your article adds a huge dimension of how quickly do I have to get the product there if it's hospital at home. And remember that the hospital at home, I need to provide the same level of care as if they're in the hospital. So I've got 2 to 4 hours to do all of this, deliver the pharmacist, deliver all the other things that, depending on what we are trying to do to take care of this patient. It's not like we can put it in the truck and it can be there tomorrow. In some cases, from a home health perspective, you can do that. So it's important for us to think about what we're really trying to get to. That time dimension for your article, it's not just 170,000 homes, it's how fast that you're trying to deliver.
Well, and the thing that, you know, I've been in these guys' seat more than anyplace else, is you're dealing with folks that have scarce resources. You're doing everything on the fly. Your system is not the same today as it was yesterday, and tomorrow's going to be even different. And yet you've got to succeed. It's picking out what things you can do and want to do to work best for your system, because you have to do this incrementally. No one's going to do this overnight. So that's how I think that you work with partners, is you pick out, well, what do we want to do? What areas do we want to serve? What services do we want to provide? And like I said, you got to have the technology ready for the people to point of use. They have to know how to use it so they don't screw it up. And it's a very difficult problem to approach. I mean, my hats off to you guys. This is tough stuff.
You know, I will say this, is, you know, follow the margin, right? I mean, the inpatient side is where we have a lot of the high spend, and we got to manage that as efficiently as possible. But when you start breaking down on the outpatient or the home, you really, I'm demanding a better understanding of the margin around that. So I'm focused on the right areas to drive that out, because you can't attack it all, but you need to understand that in order to direct your focus and priorities.
Sue?
I think the other interesting thing that is in here is, you know, there's the whole group of insurers and Medicare and all of that. And I think we're bumping up against who's paying for it? Who's paying for the breakdown of those supplies? Because, you know, as the population ages, yes, I can go here nurse or in nursing used to, send supplies home with patients that I get reamed out by the supply chain person because I was sending supplies home. And then when I became a supply chain director, I went on the meetings, I go, why do you send those supply chain? So I think we need to even look a little deeper in our core business models of how we are getting those patients out the door with what they need initially. Because it's so hard to figure out once they get home what they need necessarily, but what do they need to take with them? And not be selfish about that. However, we also need to make sure that we're getting compensated somehow for that, because otherwise we get stuck walking out the door continually. And I'm all about giving people things to take, but, financially, that's not even doable for us at the moment. So just a thought, as I was speaking, I'm thinking of insurance, but how do we get that embedded in all of this? Who's paying?
So Sue, just as a point before Christine, I'm still looking for that $1 million PO from you. Christine.
That's what I was referring to. So it sounds great, but the track and trace logistics of these books and the different cost tiers too, the physician's office versus the patient's home versus the inpatient or an outpatient surgery facility. Who is tracking that, let alone are these considered bundled reimbursements by the insurance companies? And CMS hasn't changed any of their reimbursement models. So how do we as an industry get them to evolve with these new care delivery models?
And building on top of what Chris just said, that whole thing ties back into UDI and tying the unique device identification back to what Ed's talking about, with linking with iPads and what have you, and moving stuff through from the hospital to the home, and how do you track that stuff? The real issue, $1 million, is what's the liability associated with that in terms of quality of patient care?
Yeah.
So how do you track that? How are you linking UDI and the logistics processes, not only from the supplier side, but also from the provider side to the home hospital-based care?
Any comments?
Yeah, so did you want to build on that, or?
Just a quick comment. I mean, we get a cost of healthcare in this nation is the highest of any, nation in the world. And I think we have to keep on asking ourselves when we start talking about things like this, is it actually adding value? Is it just convenience? Are we just getting an additional cost to the highest system already, the universe? So I just, as a consumer, I always ask myself that question. Is it really helping?
Yeah, no, and I couldn't agree with you more. And to all of that complexity that we just talked about, I've got one piece. I lead supply chain for my organization. I'm not the RevX dude, I'm not the risk dude, I'm supply chain. I'm gonna build wherewithal with every tool I have, including stripes that are on packages, technology, systems, data. I'm gonna build the most efficient wherewithal I can. And then with my peers in risk and RevX and operations and in home care, I'll work with them to see what the best solution is that would fit within those constraints. Can I track and trace it appropriately? Can I afford, with the margin we're gonna get or not get, to deliver product? Am I the most efficient way to do it, or is it something else? So I just kind of cordon off, and maybe it's cowardice, but we all have to be really good at what we do, and that's what the organization is paying me to do, is get very good at supply chain, build up that wherewithal so that I can answer whatever call comes for whatever kind of care needs to be delivered in the future, safely and efficiently.
Other questions?
I just had a comment. Under value-based care models, capitated models, we're going to need to find a way to do as well. And so, in pharmacy where I live, we send out 45 million prescriptions a year, 60,000 infusions to the home. So as we look at that, we're just expanding that model to add in other products.
Yeah, just as a CFO who lived at Optum 2 years ago, talking about hospital home, if you were writing an article about this as a CFO, you'd have to have the payer mix categorized so that you get to the margin point that you were making earlier. And I feel like part of what it's been like to listen to this conversation as a CFO is that we owe you, Ed. We owe the supply chain leadership in the industry a way to think about this. it's too hard, as Mark said, there's too many variables that you're trying to manage to, for us not to give you the financial framework, right? So that's just off of that perspective.
Anybody else? So we got about 5 minutes left. I'd be curious, and I'll start over here on the distributor side, but just a minute and a half. What do you see as things that you can do to impact this going forward that we haven't already touched on in terms of, this is a big deal, as you just mentioned, and as you mentioned about the cost of care in our country versus other countries. So if there are any snippets of brilliance that you've got at this point, please feel free to articulate.
I think we just came from HIDA weeks ago, and one of the councils that I was on, we were talking about this exact topic that you were mentioning about the complexity of, especially the DME market, and insurance and payers. And as complex as that is on the acute care side, the hospital side, it's, in my opinion, equally as complex on the DME, and I'll give a real quick example. I can call 5 DMEs, 10 DMEs in Chicagoland area, and I can ask them, my doctor prescribed or wrote an order for this particular product, can I get it? Here's my insurance. And I'm probably gonna get 5 different answers. Well, I know they wrote for $300, but your insurance only supplies $200 for that. Well, I'm dual, but what if I have, I've got private insurance, I have Medicaid, what does that do? Well, the different rules around it, right? And I don't put that off on the DMEs, I put that actually off on insurance, and I put that off on a lot of different factors. It's complicated, it's very complex, and I think there's so much turnover in the DME space, just that's in that space, that it's challenging for them to understand the different rules within the payer space. And at the same time, the margins are thinner than they are elsewhere. So it's hard to get the technology in place, hard to get the people in place to fully understand that. And I'm glad when you said that you owe the DMEs, because it is challenging. So I don't lay that at their feet. I think the struggle is very real in that space. And I think as a distributor, what we can do is help streamline some of that. I think we can help, whether it's on the product side, on the solution side, there are things that I think we can do on the distributor side to help with some of that, whether it's on the payer side or the product side. But I think that's going to be the future, is in that DME and home healthcare space, because that's where the market is moving. Hospitals want to push more and more procedures out of the hospital. We're trying to more home-based care, and I think as distributors, we owe it to the provider space to be very good at that, so we can partner with you and for the people that you're trying to provide for.
So I'm going to piggyback off a little bit what Ed said. I think as I go back and look at all this conversation that we just had, it is complex. There's so much going on. And I go back to the same thing. Sometimes it's important for us to stay in our lane and understand what we can control. But I think we have to continue the conversation, and we have to continue to educate across the board. There's so many different organizations. There's so many different conversations happening in different pieces and parts across the U.S. How do we find one voice and bring some of this together? I think getting people to participate in the industry and having these deeper, broader discussions, getting people involved. I think it's interesting. You go to a lot of the industry events and you always see the same people at the same industry events. And how do we get more people participating in the conversation so that we truly can implement change, but control what we can control and right, stay in our specialized lane so that we can really make progress and do something different.
Yeah.
So my little soundbite is 15%. Conservatively, that's how much we waste in our supply chain in healthcare. Talking about the lower the cost of care. If you compare the SG&A, what it costs for a supplier to get product from where it's made to the consumer, we run about 35–40% as an industry. Other industries that have very similar SKU characteristics, grocery in particular, and you could argue the corollary all day, every day, but SKU characteristics are very similar to the SKUs we handle in healthcare. They can get product from where it's made to where it's consumed on about 18–20 cents on the dollar SG&A. That, I think, is our challenge, is to get really good at what we do, get more of those people like future famers and YPAC individuals into the conversation. It was really cool at ARM this year. Laura asked at the opening session, how many people are here for the first time? Clearly a third of the audience raised their hand. Yay. And I bet a lot of them have a supply chain degree too, so they can help me get more supply chain. But I think that's our challenge. I think it's not only an opportunity or a challenge, I think it's an accountability. We just flat out in this country have to take that waste out. And I got a million examples of what that looks like, because I've got a handful of suppliers that I've sat down with their S&OP and their supply chain folks, and we've found a lot of that waste and started to trim it out. So there's really good work to be done there.
I'm gonna let you wrap it up.
So assuming that we all know what the fundamentals of managing and running a supply chain need to feel like, and assuming that we have clear understanding around the measurables, not just finance, but what we determine is the right value of the delivery of the service that we're delivering, and assuming that we have decent enough data and integrity around it, I think, if you pick the focus around any of these supply chains that we're talking about, I do feel that process engineering is going to be the more of the way of the future. The reliance on the traditional way in which we, do time studies or bring a process improvement engineer into play takes too long, and the market's moving way too fast. So the ability to bring process mining around our data to understand the flows and begin to redesign and engineer things differently, I think is going to be really imperative for us to kind of advance on what we want to do.
Terrific. Well, let's have a round of applause for the panelists. And I'll turn it back over to Barbara.
Thank you, Carl, for moderating. Carl's also the co-chair of our professional development committee, who's doing a lot of great work to do more educational opportunities, hopefully some mentoring, asking some of the different bellwethers to talk and be present. And as you can hear today, they have a lot of great insights, and your questions and things were very well taken. Now we're going to bring Ed Hiscock back, who's our class of 2022 bellwether and also a member of our philanthropy committee, who's going to introduce our capstone project presentation. And we have our capstone folks here that are going to give the presentation, and they'll have a slide presentation about their project. Ed?
Thank you, Barbara. I had the pleasure of first meeting a fellow by the name of David Dobrikowski, and don't ask me to spell that.
Which is impressive that you can pronounce that.
Yeah, it's taken me a year.
I'm feeling right home in Milwaukee, it's Polish bowler.
But that was just the beginning. So David's at the University of Arkansas, and they're building one heck of a healthcare supply chain practice at the university. And then we got talking about a couple of projects we might be able to do together. And then he introduced me to Dr. Duda, Rajiv Duda. And he is a two-time doctor running at his third doctorate in supply chain. An MD, a PhD in computer science, informatics, and then, it just makes sense to add supply chain. Actually, it makes a lot of sense to add supply chain. Right. But we were real anxious to share some data with Rajiv, talk about some problems, and he's in his final year, and I'm learning a lot about what that means for a doctoral student, final year, and building their dissertation. Had the pleasure to serve on the committee that approved Rajiv's dissertation, and there's actually 3 pieces to it, 2 of which he's offered to share with us here today, and it's a year-long journey. So he's going to share 2 of the 3 projects that relate to us and our industry with us today as part of a capstone initiative, and then be back next year to talk about the results. So this next year will be full of research and validation and a lot of work that he'll put into what he's going to share with us today. But then he'll come back next year and talk about the results in very specific studied terms. And what I think is most fascinating about this is that all of these works through university become public knowledge. So it helps us raise all ships. We can all consume Rajiv's work when he finishes this, and any of our capstone projects here at the Bellwether. That's the idea, is that we'll publish these, and these will become available to the industry to kind of help raise all ships. So Rajiv, please join me in welcoming Rajiv.
Well, thank you, ladies and gentlemen, for being here today. And thank you, Ed, for the generous introduction. I don't know if I deserve that, but I would like to present the projects that I'm working on. And I would first like to thank, so with the computer. Slides. Sorry. No. So sorry about that interruption. So I would first like to thank Bellwether Foundation for giving me this opportunity to present my work here, and of course for supporting my research, for believing in the potential of the work that I'm doing. And I would also like to thank Ed for his continuous support with the data, with all the insights that he gives me every time I meet him, and of course for introducing me with the Bellwether Foundation. And these kind of awards inspire me, motivate me to do research that not only advances knowledge for us academics, but also potentially generate actionable insights that are valuable, should be valuable for practitioners. So I will start with a very brief background on myself. As Ed already mentioned, I have a medical degree from India, so I worked in a couple of tertiary care health centers in India as a physician, right? And then I joined the Indian Council of Medical Research, which is kind of a blend between the FDA and CDC here. So they do a lot of trials, clinical trials, vaccine trials, and they also do a lot of public health administration. So I worked there in a vaccine trial project for about 4.5 years. And that was in collaboration with the International Vaccine Institute, CO. And then later on, I also worked there for about 2 years in a couple of other different public health projects. So during this time, what happened is I developed this passion of, making healthcare affordable, primarily because I saw that I found that in the Indian population, almost 70% does not have accessibility or affordability to healthcare. And that primarily stems from the issue that the Indian economy, Indian healthcare is resource constrained. There is a huge resource scarcity in the Indian healthcare system. So I thought, and I'm talking about 10, 11 years ago. So at that time, information technology was still up and coming in the healthcare field everywhere, and let aside India. So I thought I should learn from a more advanced healthcare system. So I went to the United States. And as I perceived technology to be the next big thing, I chose to pursue a PhD program in informatics. So I started my program, I completed it, and then at the University of Toledo, and then I went on to work at the Nationwide Children's Hospital of Columbus, Ohio. So during this time, when I was working with these medical centers, when I first moved to the United States, I thought, well, United States, they have all the money, they have all the advanced tech, all the state-of-the-art hospitals, so they must have it all figured out. There should be no issues in healthcare delivery in the United States. So in my 6 or 7 years of PhD program and then working as a scientist, informatics scientist at the National Children's Hospital, I found that I was wrong. Even despite having all these, resources, there is still issues in healthcare delivery, and that's why there is a big chunk of American population they cannot afford healthcare. Healthcare is still not affordable or accessible to all American people. So I started thinking what may the cause be, and as I dug deeper, I found that the issues are in the efficiency. There are serious efficiency issues in managing, in coordinating healthcare. And that led me to think about healthcare operations and supply chain management. So I reached out to a couple of my friends that were in business schools, and one of them recommended that I get in touch with David Dobikoski. Dr. David Dobikoski, he was at the University of Arkansas at that time, and University of Arkansas was the #1 supply chain program. They just moved to #1 place. I'm talking about right before pandemic happened. So I wanted, definitely, when I decided to pursue another PhD program, I wanted to be at the best place. And David, of course, was instrumental in inspiring me, helping me to get into the program. So I would like to appreciate David's for this, for giving me this opportunity to conduct my research in the University of Arkansas. So now that we started our program, I started to learn about all the academic aspects of supply chain and operations management in the healthcare system in the United States. So today, the projects that I will be presenting to you will talk about some of the things that came up during these conversations earlier. And when usually when I'm presenting this to a general audience, I would use 5-6 slides to make this point. What I'm doing is important, but I guess I don't have to do it because you guys already did it. Like the words that already I heard come up multiple times during the discussions: waste, cost, visibility, complexity. You will see all of this coming in my research. So without further ado, I will move into my projects 1 and 2, which are how we can leverage physicians' attributes, physicians' practices, right, and manufacturers' attributes, manufacturers' variations, stuff like that, into day-to-day operations of hospitals and how we can reduce waste, reduce cost, right, and point of views, right. I'm trying to do something that we can implement in the actual point of use, that is the hospitals. So we heard about all these things, all these terms, waste, cost, from you, the practitioners. Let's see what the academics say. So the healthcare operations and supply chain literature tells us that the hospitals are the revenue powerhouses. They generate up to 70% of each hospital's revenue, right? And a couple of things that they note is that they also generate 35 to 40% of the hospital's expenses. Now, if you consider return on investment, it's about 100% return on investment. So they are really important. It's really important, for a hospital's financial surgical operating costs. A couple of things to note here is that the cost of supplies, they occupy more than half of operating expenses of the hospitals. And surgical implants, they constitute a big chunk of that because they are a high cost category. The next thing is, although operating rooms, they are the revenue powerhouse, they also generate bulk of the waste in hospitals. They also generate 70% of the waste in the hospitals. And a majority of that waste is due to unused items because they were opened unnecessarily or they were opened in error. So in this study, I'm trying to look at how we can reduce that. And the scholars in this field, they have found that individuals, when they're focused, they tend to perform better. So when individuals perform any procedure, any action more repeatedly, more frequently, right, they do better. They learn from those experiences and they do better. And that results in productivity and quality enhancement in their work environments. And that applies not only to physicians, every professionals, every individual, right? So to understand what goes on in this hospital operating room context, we are trying to look at how physicians' focus can help hospitals to improve performance in terms of operating room waste and also cost of surgical cases. Of course, we also look at how variations, because if you introduce variation, you kind of nullify the effect of focus. The more variation you introduce to someone, it's more difficult you make it for them to focus. So we are also looking how variations can impact the same outcomes. So to do this, we leverage the theory called cognitive load theory. Now, cognitive load theory has been used to understand how learning takes place. And it deals with the capacity of human brain. Now, human brain, human memory has actually two separate sections. Like if you think about a computer, we have a hard drive and we have a random access memory, RAM, what we call the RAM, right? Like similarly, we have a human memory actually has two sections. One is a working memory, and the other is the permanent memory or the long-term memory. Now the working memory, right? Every information that comes to us, every information that is new, novel, that first has to come to the working memory and then processed there to be stored in the long-term memory to be used later on or to be discarded. Now, technically, theoretically, human memory, the long-term memory has unlimited capacity, but the working memory has limited capacity. What I mean by that is that in a given time, working memory has a certain limit to handle simultaneous information. So there are a couple of terms in cognitive load theory that is important to note here. So cognitive load is the total amount of work that the working memory has to do in a given point in time. So how much load you put on your working memory. And the second is cognitive interference. What that means is if I'm dealing with multiple things together, so if I'm dealing with one thing and then I move on to do the next thing, I have to allocate part of my cognitive capacity to deal with the stimulus that already been there because of the first thing that I was doing or first information that I was processing. So part of my cognitive capacity goes towards that, so I cannot focus my entire cognitive capacity towards my current job, towards the job that I'm doing now. So that is called cognitive interference. And research has shown that novel information imposes higher cognitive load and higher cognitive interference on individuals. And higher cognitive loads and cognitive interference, ultimately, they are very important and they actually reduces performance, impairs performance, and it's more important in an environment which is cognitive intensive. And surgical operating rooms are really, really cognitive intensive environments. So based on that, we hypothesize that physicians will be focused on fewer, maybe 1, 2, or 3, I don't know, but if they are focused on fewer number of procedures, they will improve performance. So that will be negatively associated with waste, and their focus will also be negatively associated to the cost of operating supplies. Second, we also take another theoretical basis to understand what happens when we increase manufacturer variation. There is this thing called best of breed approach, and this has been a big thing in the healthcare operations literature over the last year and a half, because there was this recent study published which showed that when hospitals are implementing electronic health systems, they use this best of breed approach. What that means is they select vendors, say the EMR, if we think that the electronic health record is a 6-component system, they can select six different components from 6 different vendors based on the best performer in each category. And this is called the best of breed approach. Whereas in an all-in-one approach, you select everything from one vendor, and they may or may not be the best performers in each segment, in each category. So best of breed approach has been shown that this allows pharma to enhance their performance, right? Provide the best alignment with their requirements at a given time point or with a given application. But and we also think that physicians, right, they always want the best for their patients. So they want to rely on vendors, on suppliers that they trust with quality and reliability. So we propose that this is the best of breed approach for physicians. They want they don't always want a package. They don't always want you to bring all the supplies from one vendor. They always want to trust the vendors they really rely on and they can really trust with the quality. But the best of breed approach may be more expensive because it does not let the hospitals to leverage the benefit from bulk ordering. Maybe they need to order less items, sometimes even single items, right? And they may not be able to have that bulk ordering or bulk pricing advantage. So that may be making the procedures expensive. And also, it will drive up the manufacturer variation, definitely at the hospital level, and of course, maybe a little bit to a little bit lower extent, but of course, in a case level too, it will drive up the manufacturer variation. So, based on these, we hypothesize that manufacturer variation will be positively associated with supply waste because, as I mentioned, if you increase variation, you impose more load, cognitive load on the physicians, and and their performance are impaired in that environment. And also we hypothesize that manufacturer variation will be positively associated with supply cost of surgical procedures. Now, to test our hypothesis, again, I thank Ed for his cooperation and his support in this regard. We use Trinity Health's data, right? It's a data set that comes from their orthopedic surgical operating rooms. This data set contains 1.8 million surgical items, data on 1.8 million surgical items, which were used across 2,400 surgical procedures, more than that, and then performed by more than 900 surgeons between 2014 and 2026, over the course of the last 10 years. And we analyzed this data set at a surgeon year level. And when we do that, what we see, and this is really, really basic, really preliminary analysis, we just got our hands to the data set. We see that when the surgeon's focus is high, it's the red line, it's the higher focus, and the manufacturer variation is low. So if we look at here, right, that provides us with the lowest waste. And that goes with our hypothesis, that supports our hypothesis here. And when we look at cost, though, we see that physician focus is still important. Physician focus, when the physician focus is high, still the red line here. We get to reduce the cost, right? This is cost. But counterintuitive to what we thought, that it will increase cost when manufacturer variation is higher, it actually reduces cost. Now, what we thought so far, and I welcome any suggestions or any insights that you may be willing to share with us regarding this, but what we thought is that when physicians are taking best of breed approach, maybe it's creating a competitive environment between the manufacturers, because the reps are always there. So they know that they need to compete for their businesses because someone else is taking the cake because the physician is placing their trust on a different vendor. So maybe that's what's going on when we have an increased pool of manufacturers, so the manufacturer variation is higher. But there could be other explanations, other plausible explanations to these results too. And we'll have to dig deeper in with the data set, but if you have any insights, I'll be really thankful if you could share that with us anytime later today.
Yeah, so just in a nutshell, when your orthopedic surgeon wants to be the hand guy, that's good. Let him be the hand guy, because he produces lower waste, he produces lower costs. But this whole idea of having SKU rationalization is really good for waste. So that hand guy that has more variation creates more waste. That's the guy on the left. But it's bad for cost. So as you get more manufacturer variation, counter to what we all expect, which was thought stuff would be cheaper, right? That's why we've been working for so hard to try to get our orthopedic surgeons in this case, because I think these are all orthopedic cases. Yes. To center in on a single, vendor. It actually, our results are showing that it produces, worse costs. So it's good for waste, bad for cost.
So,
I was going to say, sometimes single vendor relationships can allow for new technology introductions in this space. And they find ways to rapidly margin up their relationships. It's just the nature of that space.
yes.
When you speak about costs, are you, and the cost being lower or higher, are you talking about the cost per case, or are you talking about the relative cost, say, for example, between one healthcare organization and another? Will I get better pricing at one healthcare organization versus another one if I have more vendors? Or am I just lowering the overall cost per case if I have more vendors? Which one are you talking about?
Yes, good point. We are actually talking about cost per case. Cost, and that's also cost of supplies per case. We are just considering how much cost do you incur in terms of supplies in each case. So some of the contributions we have already discussed, and so we are thinking that this is good for, as David mentioned, it's good for waste, but may not be as good for cost. So let's move on to Project 3 now. So the Project 3, we are talking about technology. We're talking about visibility, right, and complexity, which also came up during the discussions. So, and I read this article in this healthcare purchasing news, and it is written by our very own Rick. So this article, it mentions that supply chain visibility is important, as we all heard a little while ago, right? And real-time data availability is also important. And there was another white paper that I read. It's from a technical app, like information technology type of organization. And they also mentioned that in healthcare, the topmost they have is the IoT or RFID or real-time location system. The others that they mentioned are some of the others they mentioned about here is the blockchain, AI, right? So all of these they think are the next big things in healthcare, in the healthcare space. And this same article, from many different organizations, healthcare supply chain leaders, they mentioned about real-time location systems, the importance of RFID or other real-time location systems, and how they could improve visibility in the healthcare supply chain, right? So this study looks at how how hospitals can leverage real-time location system or RTLS to improve their performance in terms of inventory management as well as cost, as well as not cost, I'm sorry, quality of care that's delivered, because that's the prime concern, right? When we are treating patients, the most important thing is that we give them the quality of care that they deserve. So let me give you a quick example here. We heard about everything from you, but this is real life example from an academic medical center who lost these devices. So these devices, and I heard someone mentioning that what goes with patients, what goes home with patients. So these devices, they are used to prevent blood clots, right? So, and this hospital, they found that these devices, they are losing these devices. Within a 6-month time span, they lost $300,000 worth of these devices. Now, you can think, how can they potentially lose them? One thing is, sometimes in the chaotic environment, they get lost, they get stuck in the closet under a ton of other stuff, nobody knows where they are. Sometimes patients may think, well, I have been using this for 5 days, so I may need it at home. So they just pack it and get going. Sometimes those patients are, transferred to a different facility. They bring a gurney near the bed, throw the patient on the gurney, and throw the gurney on an ambulance, get going. The device goes with the patient. The hospital has no clue where they are. And we have interviewed several supply chain executives, and they have told us that in their systems, they have inventory worth $1 million that are unaccounted for. They don't know where those inventories belong, where those inventories are at a given time point, right? Now, when this hospital implemented RTLS system, real-time location system, what happened is their nurses, their personnel could type on a computer screen, and this is a real screenshot from that hospital. So they could type the device name, and they could find the red dots these red dots. They are the actual locations of that device at that given time. So they could locate these devices, and what happened is once they implemented this, they found that there was a significant reduction in missing equipment right after some time of implementation of this real-time location system technology. Now, one thing is RTLS has been adopted in different contexts: retail, manufacturing, shipping. All these contexts they have adopted, but the hospitals have really lagged behind. And one potential reason behind that could be the expensive nature of these technologies. If you think about the tags that I was talking about, these are not your like 1-cent tag that you can find in any retail warehouse, which nobody cares about. If they'll get lost, no big deal. But these are tags like $5 to $7 each tag per month, per tag in rent only. So these are expensive technology, the point that I'm trying to make. And second thing is there's really very little evidence, empirical evidence in the literature to support the benefits of this type of technologies. And third point is there is always a skepticism, there is always a mistrust from the clinicians. Whenever a hospital is trying to implement some new technology, they think that the complexity of the hospital makes it very challenging to implement these technologies, and also these technologies may impair their decision-making capability, sometimes their autonomy, and then they fear that their patients will suffer, patient care quality will suffer. So in this study, we try to look at how RTLS implementation could potentially impact inventory management and quality together. And we also want to look at the potential role of complexity, hospital complexity, how hospital complexity could potentially influence this relationship. So we hypothesize that real-time location systems, they will enhance visibility, and because of that, they will reduce the inventory in the hospitals. At the same time, because they will enhance visibility and information sharing between the care providers will have more time, they will get less frustrated, because those are the things that happen when they don't find something that they need to provide patient care, right? They get frustrated, sometimes they get burned out, and even more dire consequences follow, like medical errors. So when that doesn't happen, they have more time to focus on their clinical functions, right? And that will reflect in better care quality delivered and also the perception of patients, how they perceive their care they got was delivered. So all this reflects in total performance score, which is calculated by Medicare and Medicaid, the CMS, to determine hospitals' reimbursements. So we hypothesize that when we have RTLS in place in hospitals, it will improve total performance score, in other words, performance. And we also reviewed the complexity literature in the operations and supply chain domain. And we found that the scholars are divided, the studies are divided. There is no conclusive evidence on whether it improves performance or, impairs performance. So we test a competing hypothesis. What we're really trying to say that we really don't know if it will enhance or diminish the impact of RTLS on these outcomes, such as the inventory and the total performance score. And we found that after initial analysis, we found that this hypothesis remains true, both of our, the top one and the bottom. So indeed, the hospitals that have RTLS in place, and they actually reduce inventory and improve TPS. And this is the measure of complexity, CMI. This is also calculated by the CMS for reimbursement purposes. But this is a very commonly used measure for complexity in the literature. And we found that case mix index, or complexity, in other words, actually diminishes this effect, which makes sense. So the more complex the environment gets, it's more difficult it gets to coordinate care and stuff. So even though they have RTLS in place, the effect is still there. It doesn't. I'm not saying that complexity makes RTLS not work. No, RTLS still works, but the impact is not as as big as it gets when RTLS is implemented in a low complexity environment. And for this study, we used data from CMS. That is, this is publicly available data set. We got 3 different data sets from CMS, and we compiled a unique data set which we analyzed, and we'll still need to make more and perform more analysis on the data sets to generate more insights on these. But initial results ultimately points us towards a couple of big contributions that we think we could make. The first thing is we can say that RTLS implementation improves inventory performance in terms of that it reduces inventory. It also helps in performance improvement in the clinical dimension. So clinical and patient experience. So I think it's helpful for hospital leaders to convince clinicians who are skeptical about implementing technology. So these results can help in more clinician buy-in when rolling out new technology. And second insight that I think we can generate from here is that this impact of CMI on RTLS, the relationship between RTLS and inventory and TPS, that complexity reduces or diminishes the impact is really important to consider, especially when hospital system is trying to roll out some new technology. What happens is, oftentimes, is that when a hospital is trying to roll out new technology, they select their flagship hospitals, right? The bigger hospitals with more patient care, more facilities, right? And those tend to be the more complex hospitals. Now, when they roll out new technologies such as RTLS in these kind of hospitals, the initial results they see, they may find them underwhelming, and then they may altogether postpone that pilot rollout project. And then the hospitals, the less complex, maybe smaller hospitals that could benefit more from those type of technologies, they may even never get those technologies, never even get to use those technologies. So we believe that our results also calls for more strategic deliberation and planning when rolling out new technologies in a hospital system environment. Well, with that, I'll thank.
Quick example, I was teaching healthcare leadership EMBA about 6 weeks ago and a physician EMBA 2 or 3 weeks ago, and I was talking about this study. And the whole message is, RFID, RTLS is actually good, reduces inventory per bed, actually improves the TPS score, the quality score, so that's good. But for hospitals that have higher CMI, they don't see the same results, right? Well, where do we roll out technology, right? We always roll out the tertiary care center first. And if we don't get the bang for the buck, a lot of times the community hospitals in our system may never see it. So I'm presenting this stuff, and a fellow raises his hand, he says, well, so what you're telling me is, I'm about to roll this out in a month in my ED. That's the first place I'm starting. That's probably not a great idea. I said, you're right, it's probably not. How about like the general medicine floor, maybe med surg? Start out in an environment where you can really get the advantage of the technology, right? Because then it might motivate you to roll it out throughout the system. So this is really about thinking about like facility to facility, and then ultimately how it is on the floor, not necessarily materials management per se, but you know, we're hoping that provides some insights for leaders as well.
Yes.
I'm curious if you made any correlation to implementation of RTLS to reduction in repairs on equipment.
Well, we looked into equipments and perpetual inventory differently, and we got similar results. But in terms of repairing, because this is a secondary data set, we are limited by what they have. So to answer your question, no, they don't have anything regarding repairing. So we couldn't look into that. But I think that's a great point, and it would be very interesting. Maybe it's gonna be a very interesting extension to the research, and if we could get our hands to a data set that lends itself to answering these questions, maybe that will be an interesting point to study in the future.
Yeah, that's
Thank
a great point, because obviously that's how, you know, biomedical engineering uses this stuff, right? I mean, when there's you know, an upgrade or something, right, they go out to find, you know, the supplies, IV pumps, whatever it is, and that's how they do their upgrades. So what kind of got glossed over is this is data from HIMSS he combined with CMS data from the cost report. So like the perpetual inventory number comes right off the cost report. Based on feedback that we got with that about 2 weeks ago, that, hey, you should be looking at equipment also, not necessarily repairs, but the amount of equipment. Rajiv went out and found on the cost report that there's also an equipment, it's called major movable medical equipment category. Same results as perpetual inventory. But I think that's a great point. If we can take another look at that cost report, I don't know if there's anything on there about MRO type expenses, but that would be a great addition. Thanks for that.
Thank you, Dr. Peters.
Thank you so much.
All right, everybody, that concludes this portion of the program. We want to thank Dr. Buda, the University of Arkansas, Walton College of Healthcare Initiatives, of which David is the Director of Programs there, and to Ed and Trinity Health for bringing them together. We look forward to their further reports next year and the progress that they've made. Now we have a reception for you all. So get to know new colleagues, get to visit with known colleagues, and have some refreshments with us until 7 o'clock when our big induction ceremony begins, and we're glad you're here.